Greetings from the World Health Organization. I'm Dr. Soumya Swaminathan, and I'd like to thank you so much for having invited me to share my thoughts with you. What I'd like to do over the next 30 minutes or so is to perhaps narrate to you what I see from my vantage point here at the WHO headquarters on what's happened between the 1st of January and now. What are the lessons learned? What have we been working on? And what do we have to look forward to? So on the 1st of January, in fact, we activated our incident management system because we were alerted to this outbreak of pneumonia cases in Wuhan. And very shortly after that, we put in place the systems that are needed to manage an emergency outbreak. So on the 10th of January, we started putting out technical guidance, even before we knew that it was a novel coronavirus. And on the 30th of January, when there were only 82 cases outside China, we declared this a public health emergency of international concern. And of course, on the 11th of March, this was characterized as a pandemic, the first non-influenza virus to cause a pandemic. If you look at what's happening globally, we are adding 1 million new cases every 3 days and averaging between 5,000 and 6,000 deaths a day. India, United States, Brazil are the countries that are adding the most number of cases on a daily basis, but many countries in Europe are now experiencing what looks like a second wave. This map actually shows the new cases in the last 7 days per 1 million population, and you can see the darker the colors, the higher the incidence. And similarly, this world map shows the COVID-19 deaths reported in the last 7 days per million. And China, of course, has done well, so have large parts of Southeast Asia and the Western Pacific region, as well as Africa. Now, we actually can see that there are 4 types of scenarios that countries can be divided into: those that avoided large outbreaks right from the beginning by taking early action. There were others that had really bad, severe outbreaks, brought them under control, again with very stringent actions. Some of them are now seeing a resurgence of what's called a second wave, and there are some countries which have continued to see intense transmission, and these are mostly the larger countries. Now, transmission has been something that we focused on right from the beginning, and we produced a scientific brief in July that we are going to update. And essentially, if you look at our website, you will see that we've done almost 400 guidance documents of one kind or the other on COVID-19, and another 400 or so which is related. Now, it's important to try to understand the transmission of the virus is a combination of how it transmits, when it transmits, that is during the course of one's infection, and where, the setting. And understanding all 3 of these elements is key. Now, we know that most transmission occurs by droplets, through fomites, but also through aerosols. The small droplets which can persist in the environment, and particularly in the closed environment, can actually transmit to people who are more than 6 feet away from the infected person. We know now that pre-symptomatic transmission can occur, and in fact, people are most infectious a day or 2 before the onset of symptoms to about 5 to 7 days after the onset of symptoms. And crowded indoor closed settings with poor ventilation is the venues where a lot of the super spreading events, for example, have happened. So we recommend a set of measures which include identifying and isolating cases, wearing fabric masks, especially where distancing is not possible and in indoor settings, infection prevention and control for health workers, hand hygiene, physical distancing, and avoiding those 3 C's, the crowded places, the close contact settings, and the confined spaces with poor ventilation. This is what Japan did, focusing on the 3 C's. Ensuring good environmental ventilation as well as disinfection, and preventing amplification events is extremely important. And countries which are focused on identifying and preventing clusters and amplification events have done well. We're also learning now that while the majority of people do suffer from mild symptoms or moderate illness, 10 to 15% progress to severe disease, 5% become critically ill, and we're learning how to manage these critically ill people. And therefore, case fatality rates have really come down over the last 9 months. But what we're seeing is that the milder cases recover in 2 to 3 weeks, while people who have been more severely affected take longer, 6 to 8 weeks. And in some people, symptoms tend to continue or persist. And there was a phone survey in the US, there was another one done by the BBC in the UK, which showed that about 30 to 40% of people continue to have these symptoms, mainly fatigue, but also respiratory symptoms, and loss of taste or smell, but also confusion and what people have described as brain fog. And we're still trying to understand what the pathophysiology of that is. It is now clear that it's not just a respiratory virus, that the SARS-CoV-2 virus actually impacts many organ systems, and that there are a number of risk factors which also increase the risk for venous thromboembolism. So the heart, the lungs, the brain and the nervous system, mental health issues after recovery, and musculoskeletal symptoms. One of the key functions of WHO is to develop guidelines, and this of course is a normative function of ours that we always do. So we've put in place systems to ensure that we can provide strategic guidance at the right time and provide the quality assurance that's needed despite having to do it in an accelerated timeline. So our experts are actually doing 24 to 48 hour review turnarounds, reviewing hundreds of documents, and we're also seeing an increase in the number of downloads that we get from our website. We're maintaining a regular running update also of all the research that's being done on COVID. We have a database that's you can have free access to all the abstracts, in fact, in multiple languages. And this is a big task actually to look at and scan through the publications. So you can see that these are some of the resources that we've been putting up on our website, and throughout, science has been driving our understanding, whether it's natural history and disease progression, the risk factors for death or recovery, calculating CFRs and infection fatality ratios, and as I mentioned also really trying to understand transmission, because transmission is important because that's the one that informs us of what public health actions are needed. Now on the SARS-CoV-2 sequences, we have today over 140,000 genome sequences that have been shared in GISAID. Luckily, this virus seems to mutate more slowly than other viruses like flu that we know, and the reason that we want to track the mutations is because it will inform us whether there are indications of the changes in the spike protein, which could reduce effectiveness of therapeutics, vaccines, as well as diagnostic assays, and also looking at the biological properties like infectivity and transmission. So as I mentioned, the GISAID database, which was initially set up for influenza in 2008, were very quickly able to adapt, create a platform for the novel coronavirus, and we can see that we've had real-time data sharing from over 123 countries. And also this database seems to attract scientists more than the GenBank because it has certain it puts in place certain terms and conditions which are favorable to scientists who are actually sharing their data. Seroepidemiology, another area where we've seen a lot of interest, a lot of research, over 140 publications. We know most studies up to date tell us that in the majority of countries around the world, less than 10% of the population has been exposed to and has developed antibodies to the SARS-CoV-2 virus. Of course, there are exceptions. We've seen some cities where you might have certain pockets with higher antibody levels of over 20 or even 30 or 40%. These studies are important, especially when done serially and when age and sex stratified. You can understand much more about the epidemiology of the disease. But what we need are longitudinal studies to understand more about SARS-CoV-2 immunity. What do we know now? We know 90 to 100% of infected individuals seroconvert. But we also are learning that those with mild illness, there's a minority of people who may not seroconvert, about 10 or 20%, but most who have moderate or severe illness do, and it seems to correlate the IgG antibodies with neutralizing antibodies. We're learning more about how long these antibodies last. We've, of course, heard about cases of reinfection, but there have been cases, cohort studies, which are showing antibodies last for 4 to 5 months. Since we're only 10 months into the pandemic, we have to wait and see. And we also don't know whether this is going to be sterilizing immunity or functional immunity, or whether it's going to wane like it has for the other coronaviruses, where immunity does not last beyond 1 to 2 years. Now, on a slightly different topic, a pulse survey that we conducted showed that the majority of countries reported serious disruptions in essential health services. And these services, starting from immunization, which were impacted in over 70% of countries, to maternal and child health services, malaria and TB diagnosis and treatment, NCDs, including cancer, but also urgent services like blood transfusions and essential surgery and 24-hour emergency services. So this is very concerning, because obviously the morbidity and mortality due to all these other diseases is as serious, if not more, than the COVID itself. And so we've been coming out with guidance to countries on how to balance the demands of the COVID response with the other actions that are necessary to maintain quality essential health services. And this is organized around 9 areas, and it's done with some of the other UN agencies. It's obviously key, really, that we need to be investing in human resources, because that's where the crunch comes in most countries. So our strategy for dealing with COVID-19 is around suppressing transmission, saving lives, as well as livelihoods. And we firmly believe that the debate should not be health versus the economy. It should be health and the economy. And it's a question of how do you mobilize communities and governments and all of society to ensure that while on the one hand you take the actions which are needed to control and suppress the transmission of the virus, you take actions that are needed to keep the mortality due to COVID as low as possible, while at the same time taking actions to safely open up economies, open up educational institutions, and ensure that there are social safety nets, so especially the poorest and the most vulnerable in society are protected through this period. So it's around the critical actions to reduce mortality and save lives are around empowering individuals and communities, around suppressing and reducing transmission, and around saving lives. So if we were to summarize, of course, the 3 C's is a good way of remembering this. Preventing clusters and amplification events. Why is this important? Because we know that 80% of people actually don't transmit onwards. It's 10 to 20% of people who are responsible for the majority of transmission events. And the 3 C's describe exactly where these are likely to occur. And therefore, we need to prevent the virus from entering into these locations. We have to protect vulnerable groups. We know the elderly, people in long-term facilities, but also those with underlying conditions are vulnerable. We have to make sure and encourage that individuals can adopt protective measures like masking and hand hygiening and physical distancing. And we know that in some places this is very, very difficult, particularly in many of the low-income countries and crowded urban areas. So we have to empower the communities. We have to give them the support to make this possible. And then, of course, the public health measures that we've talked about all along, about finding, isolating, testing, and caring for those who are infected, and identifying and quarantining the contacts. Now, on a slightly different track, I would like to talk to you a little bit about the development and the acceleration of diagnostics, therapeutics, and vaccines for COVID. And this is a global movement or a consortium called the Accelerator, standing for the Accelerating COVID Tools. access to COVID tools, because the two main goals of this accelerator were to accelerate the research and development on the one side, but also to ensure fair and equitable access once you have these products. So we brought together a number of global agencies as well as member states, the private sector, civil society. This was launched on the 24th of April, and I must say that within the last 4 or 5 months we've seen tremendous progress, and I'll talk to you a little bit about what we've seen in all of these areas. We, of course, launched also the COVAX or the vaccine pillar. But first, let me tell you about antigen rapid diagnostic tests, because these could be a game changer. You know that we were relying on molecular tests on the RT-PCR, which needs sophisticated laboratory environment and trained personnel. These RDTs, or the rapid diagnostics, can actually be done at the point of care in a primary healthcare clinic or in a doctor's clinic. It picks up those people who are most contagious, so who have the most viral load in their respiratory secretions, whereas a PCR test is more sensitive. We now have 2 products that are licensed for emergency use in the WHO. One is the Abbott PanBio product, and the other one is the SD Biosensor, and there are a few others which are still being assessed. On therapeutics, there's been also a fair amount of progress. You know that dexamethasone was shown in the recovery trial and in a meta-analysis that was subsequently done by WHO to reduce mortality among those who are most severely or critically ill. We launched the Solidarity trial at the end of March, essentially with a goal to testing initially repurposed drugs, but later on bringing in other drugs if possible. And the idea really is to set up a platform, a global multicentric platform, with an adaptive design so that you could stop and add arms, with the primary goal of studying the impact on all-cause mortality, because we believe that that's a very important public health goal and an endpoint to have, and also looking at the duration of hospital stay, and especially with the need for critical care and ventilation. And as you can see from this map, we have the trial going on in every region in the world, 30 countries to date participating, but many more actually wanting to come on board. We're enrolling at the speed of about 500 to 600 patients a week, and you can see this has stayed steady over the last few months, and that's because even if cases go down in one part of the world, they continue to enroll in other parts of the world, again showing that it's really worth this kind of global collaboration when we want to do studies which are not only robust scientifically, but also efficient, rapid, and cost effective. So this trial has hardly cost us anything, because countries have actually supported the infrastructure in their own hospitals and paid for the staff, etc. And the manufacturers have donated the drugs. So the first 4 drugs we studied were remdesivir, hydroxychloroquine, and lopinavir, ritonavir, with or without interferon beta. We've now completed that phase, and we are going to look at newer drugs, including monoclonals, to include into the Solidarity trial. We've also worked on other enabling sciences. As you can see here, we've worked on animal models, on assays, as well as on target product profiles, all done through our expert groups. We work with the best scientists and researchers in the world to do some of this work. Now, in terms of vaccines, it is unprecedented what's happened compared to some of the timelines for the other vaccines. Normally it takes 5 to 10 years. Here we're trying to develop it in 12 to 18 months. And part of the reason it was possible was because the genetic sequences of the virus were made available on the 11th of January. And therefore, both diagnostics and vaccine development could proceed very, very rapidly. Today, we know that we have over 40 in clinical trials, and one of the goals of the COVAX initiative, which is part of the ACT Accelerator, is to invest in as many vaccine candidates as possible in terms of accelerating vaccine discovery, also to focus on vaccine production through investing in manufacturing at risk, and then, of course, ensuring that there's equitable access to vaccines. So speed, scale, and access are the 3 goals. and we see that the current portfolio in CEPI, so the three partners in COVAX are CEPI, which is the Coalition for Epidemic Preparedness and Innovation, WHO, and Gavi, which is a vaccine alliance, which of course procures and distributes vaccines to over 90 countries around the world. And you can see that there are 9 candidate vaccines that the COVAX facility has currently invested in, but there are many more that are being looked at that are in the clinical development pipeline. And of course, the idea is to ensure that we have vaccines of different types, from mRNA and DNA vaccines to viral vectors to recombinant proteins to whole inactivated viruses. And the idea is to test as many of them as possible so that we have a good selection of safe, efficacious, and affordable vaccines for the whole world, because this is the first time we're going to have to vaccinate billions of people around the world. We've been used to doing it in the hundreds of millions. So it is quite a challenge to be able to do this, and that too in a timely fashion. Now again, we are considering launching the Solidarity Vaccine Trial, which will use a similar multi-country adaptive platform to test different candidates that are coming out from different developers around the world. And the advantages why we think this is a good idea is that by evaluating several candidates at the same time, you can increase the likelihood of finding more than one effective vaccine. We don't want to stop with the first effective vaccine that we find, because some of the better ones may be coming later. We can enroll people at a high speed in different parts of the world and accumulate data rapidly. We can eliminate inefficiencies of design to conduct separate trials, which is what is happening now. You have large trials of 30, 40, 60,000 people with for every candidate. Here you can have a common placebo arm and test 3, 4, or 6 candidates against that. And of course, it also encourages international collaboration and fosters equity of access. Now, I mentioned that there's also investment in manufacturing capacity around the world, and this is something that the COVAX facility is doing, looking for sites around the world so that you can also have large scale manufacturing of whichever vaccines prove to be safe and efficacious. Now, word on ethics, I think it's important because we've faced a lot of ethical issues, of course, over the last several months. And we've set up a global expert advisory group on ethics that has been looking at several different aspects of this pandemic, starting with looking at clinical trials, looking at the ethics of human challenge studies on the one hand, and what's the framework that one would use if one wanted to go ahead with doing human challenge studies. They've also looked at principles for the allocation of new products like therapeutics or vaccines when they become available, and laid out clearly, how a framework for allocation could be developed. And many countries are now using these principles and the framework to decide within their own countries how they would prioritize communities, because it's not just about global allocation, it's also within countries, one needing to prioritize which groups or which populations would get access first. And this group has also talked about the ethics of the use of artificial intelligence, for example, the use of contact tracing apps, immunity passports. So they've been coming out with the guidance documents and statements which really raise ethical issues and give us something to think about. Now, we have seen, and one of the things that's been very striking really is that, along with the global epidemic of the pandemic, there's also been an infodemic. So the infodemic is really the proliferation of information that we get every day through all of the different outlets, through the media, through social media, etc. And we've seen that fake news actually spreads faster and more easily, and in fact is just as dangerous because it stops people from taking the right actions. We've also seen, of course, the huge politicization of this virus in many countries, which is very unfortunate. And again, all of this, what it does is really confuse people and and does not allow them really to act on information that is accurate and credible. So we've been very proactive on this. We've engaged with social media giants, with the big technology companies. We've reached out with civil society, with young people. We have webinars. We do Mythbusters. We do a lot of social media events. We've engaged with celebrities, with other opinion leaders. We do media press conferences. Initially, they were daily for the first 4 or 5 months. Now we do them 2 times a week. And we try our best, really, to make sure that people can access credible information. And we try also in making sure that false information is taken off these sites as soon as possible. And groups like Twitter and Facebook have been very, very good about that in collaborating with us. So finally, I'd like to end with some thoughts on lessons from the pandemic and really what we need to think about for the future. I think one of the important lessons that we're learning is about the importance of investing in public health and primary health care. And we've seen that countries that over the years had invested in a good primary health care system and had a trained public health workforce actually have done much better. So if you compare Africa or some of the countries in Asia, like Vietnam, for example, which are not high-income countries at all, but they had invested in primary healthcare system. Thailand is another good example. They were able to activate the system and ensure that there was very early action and containment of the infection before it spread more widely in the community. And one of the lessons, I think, from Africa is that both governments there and communities are more used to infectious diseases. They are also have invested in community health workers. And that could be one reason why they were able to nip it in the bud, whereas we've seen many high-income countries with very good tertiary care facilities actually get overburdened and perhaps an underinvestment in the public health services has led to an erosion of that capacity. So for the future, this is going to be critical and key, with universal health coverage, with attention to the upstream determinants of health, the risk factors that we all know exist: air pollution, both indoor and outdoor air pollution, a good diet and nutrition, safe water, sanitation, mental health. All of these are things that we need to invest in if we are going to have a healthy population and protection from future emergencies. The role of science and scientists has really been, I think, at the fore, and the public has had a visibility of scientists that has not perhaps happened in the past for a long, long time. This has had its good and its bad aspects. The positive, of course, is that the majority of people seem to believe in science and in scientists. Many surveys have been done. It varies from country to country, but on the whole, people have said that they would believe what scientists are telling them, and this is very good. And this should be used again for the future to improve communication. Perhaps most scientists are not trained in communicating with people, and that's something that we need to build into our educational system so that we're able to communicate our messages in a clear way, in a coherent way, and in a language that lay people understand. The downside perhaps is that people don't understand how science works, that it's an incremental gain of knowledge, that it's not black and white, and you cannot know everything about a new pathogen at the beginning of the pandemic. And so there have been questions about why have scientists changed their mind? Are they flip-flopping? Are they confused? But it's again up to us to explain that that's the way in which knowledge is gained and improves, and it's incremental, and that scientists are working together. So one of the things that to me has been a real, bright part of this whole otherwise very depressing past few months has been the global collaboration and solidarity that I have seen among academics, researchers, and scientists really wanting to work together to support the WHO, to support the movement, to develop all of these products to share knowledge openly. Everything has been open access. The publishers of the big journals have also played their role in making all COVID-related knowledge freely available. The political will and leadership has also been key, and this is where again we've seen some countries do better than others, but clearly again, communicating the facts in a credible manner to people and coming from leaders who people trust and respect is extremely important. But also equally important, of course, is the pre-existing relationships, the trust that people have, and how much community engagement and empowerment there has been. And again, when you have countries which have strong primary healthcare systems where communities are engaged and involved in managing their own health, these are the places which have actually done well. I think exposing social inequities, this is again, this pandemic has characterized and has actually laid bare the inequalities that exist in our society. We now can see very clearly that the poorest, the most vulnerable, the people who are at the bottom of the pyramid in every country are the ones who've really suffered. And this is because of the pre-existing deprivations that they have. They've also, the people who are in the informal economy who've lost their livelihoods, and very often they have a combination of risk factors that just exacerbates their vulnerability. So even if they may not have suffered directly from the impact of COVID, they have suffered from the impact that it's had on everything that they depend on. And of course, we've seen these very dire predictions of increases in hunger, increase in malnutrition, as well as in maternal and child mortality, as well as diseases that are related to poverty like tuberculosis. So again, when we build back and when we look ahead, we need to put this group right at the front and center of our attention and ensure that anything that we're doing in the future, any investments that we're making, is going to address this group and ensure that there is equity in the distribution of health services and access to health services, but also addressing the risk factors that this group is exposed to, as I mentioned previously. And then we've had to manage the infodemic, as I just said. We've had that challenge. We've had to address that, I think, more than we've ever had to do at any time. But we've learned a lot, and we've learned that this is a multidisciplinary and interdisciplinary exercise. We've set up a group that is basically looking at behavioral insights and how we change people's behavior. It's not just by telling them to do things and repeating the same thing over and over again, but trying to understand what those levers are, what those key inputs are, which could actually help people change their behaviors. So looking ahead, I think we can be fairly hopeful and optimistic that we will come out of this pandemic, that we can see the light at the end of the tunnel. Most likely it's going to be through vaccines, but vaccines are not going to be the magic bullet that suddenly arrive on the scene one day and solve the problem for all of us. It's going to take time. It's going to take 18 to 24 months to have enough of the world's population covered with the vaccine in order to provide that level of population immunity. Until then, we will have to continue with the actions that we've all been taking now, both on the individual side, the behavioral, personal protective measures, but also what governments have been doing and will have to continue to do. Thank you so much for this opportunity. Thank you.